Hi, everybody, and welcome to the sixth lecture in our 10-part GI lecture series. For those of you studying for USMLE Step 1 or COMLEX Level 1, today we're going to talk about the large intestine, also known as the colon. Again, we'll use the same framework we've been using, and this one, unfortunately, anatomy and physiology will be pretty quick, so most of our time will be spent on the clinical conditions. So for anatomy, let's start by talking about the different regions of the colon. Starting at the very bottom left of your screen here, in your right lower quadrant, you have your cecum. Attached to that is your appendix. We also have our ascending colon, transverse colon, descending colon, and finally the sigmoid colon. So starting with the cecum, I'll just tell a few things about the cecum that you should know. It's the first region. It's connected directly to two structures. It's connected to the appendix through a blind pouch, and it's also connected to the small intestine through this thing called the ileocecal valve. They do like you to know some things with the ileocecal valve, so I'll talk about those here. Two conditions you should be aware of are intussusception and gallstone ileus. The reason why intussusception happens here, as I'll talk about, we talk about this in the small intestine lecture, what intussusception is. What it is where you have, if the bowel is flowing in this direction, you can have part of your bowel, the proximal bowel, actually move into the segment distal to it. And the reason why this is common at the ileocecal valve is that the valve itself can act as a lead point. It basically acts as a region where some of the bowel can attach to, and that allows the bowel that's proximal to it to start shifting through, and that would look something like this. Another thing I want you to keep in mind when you think about the ileocecal valve is in the condition gallstone ileus. I talk about this more in the hepatobiliary lecture coming up, but I just wanted to point out here on one of our slides from that lecture that usually in gallstone ileus, the gallstone makes it pretty far down the intestinal tract, but it ends up getting stuck at the ileocecal junction because that's the smallest point in the GI tract. And here again, this is also from that lecture. If you have a gallbladder that's eroded through the gallbladder wall, if you have a gallstone that's eroded through the gallbladder wall and into your small intestine, it can travel all the way down to the ileocecal valve, but it'll get stuck there because it's often the smallest point in our intestine. Moving on to the appendix, all I want to say about the appendix right now is that it's a blind pouch that extends off the cecum. It used to be thought that it was a useless vestigial structure, but lately there's some evidence that suggests that the appendix has some role in immune function and its microbiome might be beneficial for the host. And when you think about the appendix, you're going to probably think about the classic appendicitis and some of the complications that arise from appendicitis, such as an appendiceal abscess. And we'll talk about appendicitis later on in this lecture. In the ascending colon, also known as the right-sided of the right colon, this is useful for absorbing water and salts. I want you to remember that this region of the colon is retroperitoneal. And if I go back to our, this is the slide from our GI intro when I talk about intra versus retroperitoneal. I just want to point out that in the colon, the ascending and descending colon are the two retroperitoneal structures. It's got a very large diameter. And if you think about it, it's more watery. As we get to the more distal regions of the colon, you're going to have a less watery stool composition. It'll be more well formed like actual stool. And this plays a role. If you have a large diameter and a watery composition, it's really hard to have an obstruction. So you're not really going to get too much of an obstruction here if you have some sort of tumor on the right side of your colon. This is a slide that I'll show you later when we talk about colon cancer. And all I wanted to point out here is that if you notice our right-sided tumors, which is what we're talking about here, their main problem is bleeding. They don't really have a problem with obstruction because, like I said, it's more of a watery composition and the diameter is big enough to where it's not a problem. The transverse colon has a few things that you should recognize. It's the longest portion of the colon. That's not going to be tested. But what is tested frequently is the differentiating landmarks between your foregut, midgut, and hindgut. And we've talked about this before, but I just want to remind you that the midgut ends at the distal portion of the transverse colon, and the hindgut starts in that region. And what that means is that your first 2/3, your more proximal 2/3 of your transverse colon, is going to have a different blood supply and a different nerve supply than the distal 1/3 of your transverse colon, because embryologically they arose from different regions. So here you go. In the blood supply, we have our SMA, our superior mesenteric artery for our proximal 2/3, and our inferior mesenteric artery for the distal 1/3. And for our parasympathetics, we have our vagus nerve for the proximal 2/3, and you have pelvic splanchnic nerves that supply the distal 1/3. Two other landmarks I want you to be aware of as they pertain to the transverse colon. First, we have our hepatic flexure, and this is the region that connects the ascending colon and the transverse colon, and I've circled it to the image on our right. A more important landmark that you'll get tested on is the splenic flexure, and this is the connection between the transverse and descending colon on the right there. And why this is important is because the splenic flexure is actually what's considered a watershed area. This is the first time we're going to talk about watershed areas. And what I want you to know about watershed areas is that those are regions with very poor perfusion pressures. And because they have such poor perfusion pressures, they can be susceptible to ischemia. Usually this happens during periods of systemic hypotension. So if somebody's in shock, these watershed areas are often the regions that are most likely to be damaged by these incidents. And we have two watershed areas in our colon that I want you to know about. The first is what we just talked about, the splenic flexure, highlighted to the right. And the second region we should be aware of is the rectosigmoid junction, which is located right here. Moving on to the descending colon, also known as the left colon, again, this is a retroperitoneal structure. And going back to this slide, you can see the descending colon is included. And this is more responsible for storage of feces. It's less responsible for absorption. At this point, most of the absorption has already been undertaken place. And keep in mind, because there's a decreased diameter in this region and the stool has more of a solid composition, you're at a higher risk of obstruction if you do have a tumor growing on your left side. So again, going back to this slide that we'll talk about later, you can see that left-sided tumors are known to cause obstructive symptoms. And the last section of the colon that you need to know is the sigmoid colon. It's the final segment of the colon before it reaches the rectum. It's actually named because of the sigma shape that it takes. And we'll talk about some of these conditions later on in this lecture, but I want you to remember that conditions like diverticulosis and sigmoid volvulus are very common in this region. Moving on to blood supply, most of the blood supply to the colon is fairly straightforward. Just remember that because it has midgut and hindgut origins embryologically, that you're going to get blood supply from both the SMA and IMA, depending on where you are in your colon. So starting with the cecum and appendix, because they're part of the midgut, you should expect them to receive blood from the superior mesenteric artery. And so it's going to come from superior mesenteric straight to the ileocolic artery, which is the yellow arteries here in this picture. For the ascending colon, that's going to go from this SMA to the right colic artery. And then for the proximal 2/3 of the transverse colon, that's going to go straight from the SMA to the middle colic artery. Now moving on to the regions of the colon that are supplied by the hindgut, or the IMA, the transverse colon will be supplied by the inferior mesenteric artery, which will branch off here to the left colic artery and eventually attach to the marginal artery here to supply this distal region of the transverse colon. The descending colon has a little easier route. It just goes straight from the IMA to the left colic artery. And the sigmoid colon also has a pretty straightforward route going from the IMA to the sigmoid arteries. Again, here's the picture of the watershed regions we just talked about. Well, actually, first, before I talk about watershed, I'm going to talk about this marginal artery anastomosis, excuse me. So this is an important connection. We've talked a little bit about anastomoses in the stomach lecture. So in this case, we have an anastomosis, as you can see up here. And what's nice about this is it actually connects a region of our superior mesenteric artery to our inferior mesenteric artery in this circle right here. And what's good about this is that occasionally this could protect you if blood flow is, if a vessel is obstructed for whatever reason. So for example, if this region here, let's say there's some sort of clot in this region, normally distal to that clot would be at risk of hypoperfusion. But in the case, because of this anastomosis, we can actually have blood that travels all the way around and supplies this region. And I'm just going to take just a second. I'm going to delete that. Something that confused me, I remember this during medical school when I was studying for step 1 myself. I was confused by why this area would be safe, even though we described it as a watershed region. The difference between those two statements, if this is obstructed right here, let's say, and you still have very good perfusion, like your blood pressure is still good, then it's no problem for the blood to get all the way over here. And that's why the anastomosis works. It's only in conditions where you have systemic hypoperfusion, where you don't have really good blood supply, blood pressure to get the blood pumped all the way out here. That's when you run into those problems. I just wanted to make the distinction there between a watershed and an anastomosis, why the anastomosis works in this spot. And so here is the watershed region I wanted to talk about. And we've already kind of gone over it, but the only thing I wanted to point out in this slide is kind of how it works. I know 2 arteries are supplying this region, so it seems like you might get better supply. The problem with that theory is that the pressure way out here is far, far less than the pressure you get here. So what do I mean by that? Let's say if you measure the blood pressure at these spots, right here, this is coming straight off of the aorta, so and the IMA. So you're going to get very strong pressures coming in here. And as we go distal, you can see how the pressures start to lighten up. And now that this kind of makes more sense, that even though you have 2 arteries supplying it, you can see that the total perfusion of this area is much less than, let's say, this region here, even though this only has supply from the inferior mesenteric artery or left colic artery. Just a few features that you should know about the large colon. They're pretty low yield, but it's good to know what a Haustra is. The Haustra are these small pouches that you see throughout the colon. You can see them all right here. Here's a Haustra, here's a Haustra, boom, boom, boom. And they give them this segmented appearance. And the Taenia coli are these longitudinal muscles that span the colon. You can see only one here. There's actually 3 of them. And what you should know is that all 3 Taenia coli converge at the root of the appendix. Again, very low yield. I don't think that's been tested. That gets pimped on some surgery rotations. So that's sometimes good to know. Otherwise, it's kind of useless. Physiology, the colon physiology is extremely straightforward. It can absorb materials, it absorbs water, electrolytes, and vitamins, and it can move food down the GI tract for excretion. And there's some microbiota function. We need some healthy bacteria in our colon to help digest certain substances and to create certain things like vitamin K. So as promised, I told you anatomy and physiology is pretty basic for the colon. So we'll move on to all the different clinical conditions that arise in this region. And we'll first start with appendicitis. So appendicitis, I mean, you see the itis at the end, and that should always make you think of inflammation. And it is acute inflammation of the appendix, often due to obstruction. The obstruction itself can be caused by, it's more likely to be caused by different things in different age groups. So in adults, it's most commonly caused by a fecalith or just a ball of stool. And in children, it's often caused by something called lymphoid hyperplasia. So let's kind of go over what that looks like. if we have our small intestine here to the right, and remember the bolus of food will come in here to the large intestine and travel through, and attached to our cecum here is our appendix. And what happens in the first cause of a fecalith is that if you have a ball of stool stuck here, you no longer have drainage from your appendix. And so what's going to happen is that it can cause back pressure and inflammation and bacterial overgrowth in that region. In children, you sometimes get lymphoid hyperplasia, and that's because you can have lymphoid tissue that grows too big, especially in response to like a viral infection or a vaccine, and that could also cause appendicitis in children. This is going to present with fever, nausea, vomiting, loss of appetite. And they have a classic pain pattern that will be tested, which is this initially starts as a generalized abdominal pain and that ends up localizing to the right lower quadrant. Let's talk about what this looks like. So this looks like first you get this generalized, diffuse, periumbilical, that just means around the belly button, abdominal pain. And over time, that pain will migrate and it'll be very, very localized to McBurney's point after some time. So what's McBurney's point? McBurney's point is the distance 1/3 of the distance between the right ASIS and the umbilicus. So there's our umbilicus, and I've attached that on one end of this green line here, and the ASIS is located approximately here. So 1/3 of the distance is McBurney's point. So you get localized pain here. And so why does this pain pattern happen specifically? Recall that all of our GI organs are surrounded by a visceral and a parietal peritoneum. So we have our visceral peritoneum first, and that's surrounded by a parietal peritoneum. And remember that the visceral peritoneum would be affected first, and it would cause this diffuse abdominal pain. And the parietal peritoneum, which is more localized, can cause this pain at McBurney's point specifically. I'm going to take us a step back to our GI intro lecture where I talk about intra versus retroperitoneal organs, and I show this here. In this image, we can see this is our visceral peritoneum because it directly surrounds our organ, in this case, the appendix, and here's our mesentery. And this area all the way around here is our parietal peritoneum. And what you need to know is that the visceral peritoneum shares the exact same nerve supply as our organs, which are very poorly localizable. Like if you ever have a heart attack, you're not going to just point to one spot and be like, this spot is very, very painful right here. It's often this generalized chest pain that might radiate to your arm. Whereas if you ever pulled them, and then if we look at the parietal peritoneum, this shares the same nerve supply as your muscles. And if you've ever pulled a muscle, like a cramped in your abdomen, you knew exactly where that muscle was that was cramping. And so I'm going to show this in pictorial form. In appendicitis, this will start to get inflamed first, your visceral peritoneum. And remember, that's poorly localized pain. And over time, you'll start to get pain and inflammation spreading all the way here to your parietal peritoneum, which is much more well localized. For the evaluation of appendicitis, there's a few tests you need to know. You first need to know some basic things. You'll often have a patient with guarding, and rebound tenderness is common. And you'll also find out that appendicitis has a few special tests that you can do to help guide your diagnosis. So first off, rebound tenderness is important to know. Rebound tenderness is pain that is worst once you remove abdominal pressure. So you normally, if you press on somebody's belly, that's going to cause the most pain. But in some serious cases, if you release that pressure, that can cause even more pain because they already have peritoneal inflammation. So imagine I'm pushing down on this person's belly and I let go, and that's when it causes this abrupt pain. That's a positive rebound tenderness. And if you see rebound tenderness, you need to think this is peritoneal inflammation, and this is very bad. This is often a surgical emergency if somebody's having rebound tenderness, because most of the conditions, and I just have a picture of the appendix here, if it's localized here, you won't get rebound tenderness. But as you start to invade and inflame the peritoneum, that's when you're going to see rebound. And again, it's often indicative of emergent or urgent operative repair. We'll see it in appendicitis. You also see it in a few other conditions. Oftentimes, if you have anything rupture in your GI tract or GU tract, sometimes you'll have this rebound tenderness, and all of these right here that I've just mentioned are also surgical emergencies. The special tests that you need to know that are specific to appendicitis, we'll go through those now. The Rovsing sign is where you push on the left lower quadrant, and then you get pain at McBurney's point in the right lower quadrant. So imagine I push here on the left side, and there's pain on the right side. The psoas sign is where hip flexion yields right lower quadrant pain. And this should be straightforward if you know that the psoas is one of your primary hip flexors. So you just flex your hip up. So you basically raise your leg up to the ceiling and you get pain there. That's a positive psoas sign. The last thing, the obturator sign, is where you internally rotate the hip, and that also reproduces this pain. So if you imagine you internally rotate your hip, you get pain there, that'd be a positive obturator sign. And so each of these three signs give you an idea that you might be looking at appendicitis. You could also, for your evaluation, do a CT scan, and that usually shows an enlarged appendix. They don't like to test you on too many things with CT scans in step one, but I do think appendicitis is a common one. They want you to know where the appendix is, and they want you to see this widespread inflammation in this area. They want you to know that this is not a normal looking appendix. Oh, and one thing I wanted to point out with imaging, I don't know if it's tested so much in step one, but you do see it in step two sometimes. They'll give you a patient who has classic signs of appendicitis, but then they'll tell you they're pregnant, or it's like it's a kid. And in those populations, you'd prefer to avoid the CT scan for the contrast. So just remember, you could also use an ultrasound or an MRI if you need to. Another thing with your evaluation, you'll probably get a CBC, and just note that on tests, the white count is almost always elevated. I don't think I've seen an appendicitis question where it's not, for step one at least. But just realize in real life, it's not all, you can have like a normal white count and still have appendicitis. So what are some complications? Just know that if the inflammation worsens and your appendix keeps swelling, you could perforate, and that'll often present with somebody who's got this really, really severe abdominal pain, and all of a sudden they feel fine again, and which is a bad sign. Paradoxically, you would think that's good, but that could mean that their appendix actually burst. And you'll get peritonitis with that. And then you could develop an abscess. So if you ever heard of somebody who had appendicitis and they might have just been, they either had it surgically fixed or antibiotics, and maybe they got better for a few days and then now they're worse, or they just never got better, they just continued with a fever for like a week straight, that's when you should start thinking about the possibility that they have some sort of abscess. So to treat appendicitis, it's often treated surgically with an appendectomy. I did put a couple asterisks here. When I took step one, appendectomy was always the answer. And I think it still is, but I've heard recently that they're trying to move the guidelines to where you can give antibiotics in certain cases. So I would defer to the most up-to-date resources on that. I would still pick appendectomy on if I took step one even right now, just because the boards tend to lag behind. But I just wanted to put that asterisk out there just in case somebody else tells you, or one of your professors tells you for your GI specific exam, that they want you to give antibiotics in some certain cases, to keep that in mind. Let's move on from appendicitis and talk about IBS, or irritable bowel syndrome. So IBS is a disruption in your intestinal motility, and it's this constellation of symptoms. You can get abdominal pain, bloating, flatulence, you can get constipation, diarrhea. And again, because you can get all these symptoms, it's often subcategorized by whether or not it's constipation predominant. So that'd be like IBS-C. You can get IBS-D for IBS that's diarrhea predominant, or you can have a mixed picture. On exams, I've never seen IBS in a male on exams. It's almost always some sort of middle-aged woman who's got all these GI complaints. So that's something to keep in mind on test day. If you give an evaluation of somebody with IBS, you're going to get normal laboratory findings. The colonoscopy will also be normal. In order to diagnose this, you need to use something called the Rome criteria. And for the Rome criteria, you just need 2 out of the 3 criteria. It could be pain related to defecation. You can have a change in stool frequency or a change in stool form. So you need any 2 out of these 3. And again, on tests, I don't remember if I've ever seen an IBS answer where it wasn't related to defecation. Like they wouldn't just make these 2 the criteria. That's kind of more of a per anecdotal experience. They almost always, they love talking about how there's some sort of pain or symptoms that are related to the act of actually using the restroom. For treatment, it's often managed just with lifestyle modifications, including like a high intake diet. I mean, a high fiber diet, excuse me. So that's usually how it's managed. That's all you really need to know about IBS, just middle-aged woman, some non-specific GI symptoms, normal testing, and just remember this pain related to defecation here. Now let's move on to the longest section of our colon lecture will be either this as well as the colon polyps and cancer. But this Crohn's and UC is super high yield. So I'm going to break it down for you. I'm going to try to make it easy for everybody to understand because there are a lot of features to this. And it can get confusing to differentiate which feature is part of Crohn's, which is part of UC. So let's break it down. And for this part, I'm going to talk about some of the similarities between Crohn's and UC. So if you haven't already just inferred that from what I'm saying, there are 2 subtypes of IBD, Crohn's and UC. What happens in both of these diseases is that you have some sort of autoimmune dysregulation that causes inflammation of your GI tract. There's some risk factors. Oftentimes on test, the person who's getting this disease is going to be in their late teens through their 30s. In real life, you can have people with Crohn's who get it in their 60s. There's like a bimodal distribution, but on tests, always consider teens through 30s. It's going to be more common in females, but I don't want you to assume it's just in females. They will test on both. And for race, it's often Caucasian or Jewish descent. And how is this going to present? It's going to present first off with relapsing and remitting symptoms. So you might have a flare up for a couple days to weeks, and then it might go away for a while. You'll be asymptomatic. And the big things to recognize with IBD is you're going to get this abdominal pain. You're going to have diarrhea, oftentimes bloody diarrhea. That's a really good giveaway on tests, and fever. Another thing they love to test about IBD, whether it's Crohn's or UC, is they love to give you a question of somebody who's got these non-specific GI symptoms, and they also have these extraintestinal manifestations. So what kind of extraintestinal manifestations am I talking about? I'm talking about all these inflammatory conditions I listed below. And I'm going to go through each of these really quickly so you have an idea. So here's a picture of uveitis, or inflammation of the uvea. You can have sacroiliitis, which you can see right here on this picture here, inflammation of the sacrum. And you can see aphthous ulcers right here, this gray ulcer with a red bold border, which we actually talked about in our oral cavity section. 2 other manifestations that can come up are erythema nodosum, and these are painful lesions in the shins. You can also get this, and I think this is their favorite testable extraintestinal manifestation. It's this pyoderma gangrenosum. And how they like to test this, they like to give you a patient who's got bloody stools and fever, and they show you this, and they say, what do you want to do with it? And some people they'll always be an antibiotic as an option, and that's wrong. This is an autoimmune condition, and this is actually an autoimmune extraintestinal manifestation. So you need to treat it with steroids to actually cure this, to alleviate this condition here. So we've talked about some of the similarities. How I'm going to break this down for your learning pleasure, I'm going to go over each of these features here and go over the differences. So we're going to talk about the location and progression of each of these diseases, how thick the inflammation gets between Crohn's and UC, and we'll talk about a few different findings. I'm going to show you the differences in imaging findings, colonoscopy findings, as well as biopsy findings. And then we'll finish off with different complications that can arise, whether you have Crohn's versus UC. So let's start with Crohn's, and we're going to put those 6 features on and kind of go over what Crohn's looks like, and then I'll do the same with UC so we can differentiate the two. So Crohn's, the location of Crohn's is very interesting. It can pretty much exist anywhere along the GI tract. It doesn't have too much rhyme or reason to it. And I remember this by the mnemonic, Crohn's has no zone. It's not, specific to the distal colon or anything like that. It can be in your oral cavity or what have you. It does have a predilection for one spot, and they love this on tests. They want you to know that Crohn's often affects the terminal ileum and cecum. So if we go here to our diagram and see where exactly this could be, you could have a person with Crohn's who has inflammation in these regions, and that wouldn't be unusual. It's very often to skip sites. And it invades the terminal ileum, which I have in the bottom left there, circled now. And just remember about the terminal ileum when we talked about our small intestine lecture. The terminal ileum is really important for vitamin B12, and because it also is the spot where bile gets reabsorbed. If you have a terminal ileum problem, you can have B12 and fat malabsorption as well. My mnemonic for remembering the locations of Crohn's versus UC, I just take their letter, the C versus the U, and I think about the inflammation being on the I don't know what to call this, like the horseshoe end of the letter. So in this case, if we have a C, the inflammation's kind of at this bulky end here to the left, and that reminds me, okay, it's going to be, if I'm looking at a body here, it's like on the left side of the colon where I'm having all of my inflammation in Crohn's. For the thickness of inflammation, it's really important to realize that Crohn's disease is transmural inflammation, which means it bores through all 4 layers of the GI tract. And I remember this by the mnemonic, Crohn's digs to the bone. It gets all the way through. So if this is our GI tract, we have our lumen, our mucosa, submucosa, our muscular layer, and then our serosa or adventitia. And in Crohn's disease, you have transmural inflammation. So it gets all the way through each of these layers. On imaging, you're going to see a few different things. The first thing you'll see is something called the string sign. So here is an example of the string sign. And what I want you to know, the name kind of speaks for itself, where you can see how there's a lot of these bowels that look like strings. So that's actually the thin intestinal lumen that you can see on imaging studies. And I've highlighted them here. And this actually happens because of intestinal strictures. So if I put our GI tract layers again, what can happen is that if you have inflammation of all these layers, sometimes the inflammation is replaced by scar tissue or connective tissue, and that connective tissue has some contractile abilities. So that connective tissue can actually contract and bring the lumen closer together. And that's what gets you that stricture and that string sign. On colonoscopy, you're going to find a cobblestone appearance. And so you're going to think about the stones in Crohn's. You'll also see creeping fat as well. So let me talk about these really quick. Here's cobblestone mucosa on the, here's cobblestone mucosa on the left here. You can see this kind of looks like a cobblestone pathway. Remember the stones in Crohn's. And you also see this creeping fat here invading. And I just wanted to mention what creeping fat actually is. So creeping fat, oh yeah, how I remember that as well is the CR in creeping fat, the CR in Crohn's. That's a pretty good way to remember it. But I more often, instead of using the mnemonic, I just think about it logically. And how that works is that if you have transmural inflammation, so you have inflammation going through all of the GI tract layers, what can happen now is that the inflammatory cytokines that are released from this transmural inflammation can actually attract the fat and start to bring the fat over. So this fat starts to come over because of this cytokines. And we're not going to see that in ulcerative colitis because we'll find out later that ulcerative colitis only causes inflammation of the first two layers. And so there's no cytokine release that can draw this fat into this area in the first place. But if this mnemonic still helps you, the creeping fat and Crohn's, by all means use it. On biopsy, you're going to see something called non-caseating granulomas, which are a Th1 mediated process. Here's some granulomas to the right here, and it's a Th1 mediated immune response. When I think of granulomas, I always think of the granuloma garbage can. It's kind of a garbage can that all of our material that we don't really know what to do with, we just kind of package it up in these big, granulomas, and we just kind of don't even worry about it after that. How I remember this in Crohn's is that I remember that first off, you can do granuloma equals granulona for Crohn's disease. Another way, I think I saw this, I can't remember if it was Dirty Medicine or somebody else who had a pretty good mnemonic about Crohn's and UC. And they basically put Crohn's, instead of Crohn's, they made it Crohn's, like with a 1, to remind you of a Th1 mediated response. And so that'll kind of give you an idea that it's granulomas. Either one works, whatever kind of works for you, to remember that these granuloma garbage cans are a histologic hallmark of Crohn's. There's several complications in Crohn's, and I want to go over these to make sure you understand why they are. The last thing I want is for you to have to memorize 5 different complications and just hope that you remember their Crohn's versus UC. It can also cause malabsorption, and you probably have some idea of why that may be because of its location in the terminal ileum. Let's start with strictures, though. We already saw the string sign, so we kind of understand how strictures already work. You have this inflammation, it's transmural, it's replaced by this connective tissue, and boom, you can contract that in, you get a stricture. Abscesses, I don't have a good slide on abscesses, but just know that because it can infect all of the layers of that GI tract, all 4 layers, it's more prone to fistulas, it's more prone to abscesses. It's a little bit more dangerous when it comes to that. Speaking of fistulas, I do have a nice picture on fistulas. A fistula, if you don't remember, is a abnormal passageway between 2 different organs. And the only reason that fistulas are even possible in Crohn's is because they are able to invade all 4 layers. So again, we have invasion of all 4 layers. And now if you have an adjacent organ, what can happen is that inflammation doesn't just stop once it passes through this serosa and adventitia, it continues on to the adjacent organ. And the problem with that is that if you have this continuous inflammation, this area doesn't turn into like this well solidified structure anymore. You can actually get the formation of this passageway between the 2 now, and that can form a fistula. And they do love this on a test. They'll give you somebody who has some of the classic Crohn's symptoms, like, oh yeah, bloody diarrhea, fevers for a long time. And then they'll say something like, this person has also had foul smelling urine with gas in it. And that should make you think, I wonder if it's actually Crohn's because there's some fistula going on between the GI tract and bladder, and stool is actually getting in here and then exiting through the urethra. Moving on, so gallstones and Crohn's is kind of interesting. We haven't talked about gallstones yet, but so I'm gonna go over it just a little bit here. We go into detail in the hepatobiliary section if we need to remember that. What I want you to know for now is that gallstones, bile is a big component of gallstones, okay? And bile I go over in a ton of detail in hepatobiliary. What you need to know right now is that bile is mostly water, but it's got some solutes in it, okay? It's got 4 main things you need to know. It's got bile salts and acids, which actually, I should mention, the bile salts are a pretty good, they reduce the amount of gallstones. They kind of keep everything fluid, so it's actually helpful. If you have a lot of bile salts, you're not going to have as many gallstones. The two common offenders for gallstones are cholesterol and bilirubin. And if you get too many of either of these, you can have a cholesterol gallstone form or a bilirubin gallstone. And the fourth category is just this kind of broad other category. It's really low yield. You really just need to know the cholesterol, bilirubin, and then the bile salts. So in the case of cholesterol gallstones, those can form in two different ways. You can either get a ton of cholesterol in your bile, which will, supersaturate your bile and predispose you to cholesterol gallstones, or you can have it where your bile salts or acids decrease. Technically, if your water decreases, that can also, so like if you're really dehydrated, you're at risk for both cholesterol and bilirubin stones. But just for this example, this is fine. Either high cholesterol or low bile salts will cause cholesterol gallstones. In Crohn's disease, specifically, you're going to have decreased bile salts and acids, which can increase your risk of cholesterol gallstones. This is from our small intestine lecture, and I just want to point out that if your terminal ileum's not working here, you might get a bile salt deficiency, right? So if you have damage here, you can easily have a deficiency here. And how that works is that in our small intestine, when we're trying to absorb fats, what happens is that as the micelles of fat are absorbed into our enterocytes, the bile that was used to facilitate that process cannot enter these cells. And instead, that bile has to travel all the way down to the terminal ileum, where some of it gets reabsorbed and it can kind of repeat the process over and over. The problem, though, is that if our terminal ileum is damaged in a condition like Crohn's, you're going to lose this ability to reabsorb bile. And so you're not going to get any more bile. And so if that was the case, you'd have an overall deficiency in bile salts and acids, and you can get cholesterol gallstones. Another thing I want to mention with Crohn's disease is nephrolithiasis or kidney stones. So how does that happen? Well, in Crohn's disease, the most common kidney stone you're going to see is calcium oxalate stones. This should be easy to remember because this is the most common kidney stone in the general population too. There's two primary reasons why people with Crohn's are predisposed to these kidney stones. The first is a more general principle. It's if you're dehydrated because of this chronic inflammation, you're going to be more prone to kidney stones, just like you'd actually be more prone to gallstones if you had dehydration. The real thing that they want you to know, the mechanism by which this happens for Crohn's, they want you to realize that there's increased oxalate levels in our bloodstream in Crohn's. So how does that happen? What's going on here? So we just saw this diagram, and we learned that if we have damage to our terminal ileum, we lose this potential and we lose all our bile. The problem is bile was what was helping us absorb all those fat molecules, or break them down at least, right? Emulsify them. And if we don't have that, we're going to have a lot more fat that can't enter our enterocytes. It's just too big. And that fat can start traveling down our GI tract. Note that here, that in our GI tract, we usually have calcium that's bound to oxalate. And if calcium is bound to oxalate, this oxalate can't escape, and this will all get excreted. The problem is that these fat cells love calcium. So they'd be happy now that they're here in the GI tract hanging around. They love to bind to calcium. And when they bind to calcium, calcium loses its grip on these oxalate molecules. And because of that, oxalate's able to freely diffuse into our bloodstream. So you get all this oxalate that's entered into your bloodstream that really wasn't supposed to be there. It was supposed to have just, been excreted, bound to calcium, and nothing would have happened. But with this free oxalate in our bloodstream, you can get calcium oxalate kidney stones. The last thing I want to touch on is malabsorption. So you can get fat malabsorption, fat-soluble vitamin malabsorption, and B12 absorption. So for fat-soluble vitamins, what I want you to remember is that we went over this in the small intestine, but this is just a brief reminder that vitamin A deficiency usually presents with either skin symptoms and eye symptoms. Vitamin D is classically associated with bone problems or hypocalcemia. For vitamin E, really remember that hemolytic anemia. And vitamin K, just remember it's a bleeding risk because you need vitamin K to synthesize several of your clotting factors. And of course, vitamin B12 absorption will be tested on your shelf in the setting of Crohn's disease. This is a picture of our B12 absorption, which I talk about extensively in the stomach and small intestine lectures. What you need to recognize here is that in Crohn's disease, well, actually, for normal B12 absorption, you need a healthy terminal ileum, and that's because this complex right here gets absorbed at that location. So in Crohn's disease, though, you have a defective terminal ileum, so you don't get this, and that means you lose your B12 in your actual blood, and so you can get a B12 deficiency. So we've talked about the 6 features that I want you to recognize in Crohn's. Now I want to contrast it with ulcerative colitis. So in UC, what I want you to realize is that instead of skipping lesions like Crohn's and kind of having no true rhyme or reason other than the terminal ileum, UC is a lot more logical. It always starts in the rectum, it always involves the rectum, and it continues up proximally. So what that looks like is that the UC will start here, and as the disease progresses, you'll get inflammation here and so forth. And I remember this by thinking of the letter U and realizing that this curved, whatever this horseshoe curve is called, is at the bottom of the U, which reminds me that the progression always starts at the bottom of our body. Instead of Crohn's, where we had the C, which would cause the inflammation to kind of be over here toward the left in the terminal ileum. For the thickness of inflammation, instead of transmural inflammation like we saw in Crohn's, you're going to see it in the mucosa and submucosa. So what that looks like is this region here instead of that transmural inflammation. On imaging, they love this X-ray that shows the lead pipe sign. They're going to test this. What lead pipe colon looks like is a loss of haustral markings on imaging studies. And so here, you can notice in this region here, you have beautiful, healthy colon here. They have their haustra. Remember the haustra are those segmented balls? You can see the subdivisions here. You can see one here and here and here and here. I'm going to draw these lines here so you can kind of see, even here and here still has that nice outline of the haustral markings. In ulcerative colitis, though, you lose these haustral markings. So you end up with this very, like they say, like a lead pipe. This happens because normally, if this is a healthy colon, we have our Haustra and our Taenia coli. What's going to happen is that this chronic inflammation here will damage it so much that it loses its definition here. And that's why you get this structure here in the affected colon. If you can imagine the inflammation is kind of coming up here, and causing damage. And that's what's causing all this. And you can see that UC has not progressed to this region here because it still has all of its Haustra. On colonoscopy, you're going to see pseudopolyps, which look like this. This is kind of a weak mnemonic, but I remember it as the UC equal. I remember the U in pseudopolyps kind of sounds like UC a little bit. But honestly, I just remember that the stones are in Crohn's and then UC is kind of the other one, if you want me to be honest with you. You don't have to memorize everything. Sometimes it's good to memorize one thing really well and just know that the other one is the other one. On biopsy, you're going to find crypt abscesses, which are Th2 mediated. So this is a healthy crypt here. Oops. What I want you to realize is that these crypts here are huge and there are a lot of them. If you go into the small intestine lecture, I talk a little bit about the crypts of Lieberkühn and what cells live there. And you can just see that these ones, the abscesses develop in these areas, and that's typical of UC. There's a few complications you got to recognize with ulcerative colitis. The first being colon cancer. You can also get a condition called toxic megacolon. And what I like to refer to as a complication of UC is primary sclerosing cholangitis, which is a hepatobiliary condition. So starting with colon cancer, We'll go into colon cancer in detail. I was looking at the screening guidelines of this. What you need to know is that the longer you've had UC will increase your risk of colon cancer. And because of that, the screening guidelines kind of match that. Right now, here's the colon cancer screening guidelines. If you have a diagnosis of UC, you should have your first colonoscopy 8 years after the diagnosis. There's actually some like leeway, like if you only have a small area affected, you can wait like 12 or 15 years. But if you have like a ton of pancolonic involvement, you should have it done 8 years after your diagnosis. You don't have to remember those numbers, by the way. The important thing you need to know is just this relationship between UC and colon cancer. And here's some other guidelines that this is, like I said, this is not going to be tested, but if somebody does have a diagnosis of UC, you have to get a colonoscopy, and then you have to keep following up with colonoscopies pretty often, every 1 to 2 years. And the big thing you should recognize is that because UC has this gradual progression, if you remove the affected colon regions, you'll actually improve, you'll prevent colon cancer development, and you'll actually cure them of UC. Another complication to keep in mind is toxic megacolon. So toxic megacolon is caused by inflammation because of damage to nerves in the myenteric plexus related to that chronic inflammation. Because of these damage to the myenteric plexus nerves, you're going to get a decrease or absence of peristalsis, which is our normal movement of our stool burden throughout our GI tract. So remember, we have our lumen, mucosa, submucosa, our muscular layer, and our serosa or adventitia. In our third layer, our muscular layer, we have a few important structures. We have our inner circular muscle layer. We have our myenteric plexus, also known as Auerbach's plexus. And how I remember its functions, I remember the M in myenteric for the M in movement. So that reminds me that, okay, this is causing the myenteric plexus is important for movement or peristalsis. And just remember, you have an outer muscle layer here. And one more thing I like to point out every time we talk about the myenteric plexus is that it also regulates sphincter tone. And that's why achalasia, when we talked about in the esophagus lecture, is also a myenteric plexus problem. So remember, it regulates peristaltic contraction. So if you don't have peristalsis, this region here is not having any peristalsis. It's nothing's going right here. Nothing's moving along. So what's going to happen is that right here, proximal to that, everything's going to back up. So even though this looks like the worst area because it's all big, this is actually the area that's affected, if that makes sense. The normal appearing area is the area that's already been damaged so much that it can't propel food into this region, so it just backs up proximal. And this thing, as you can see, it's already getting bigger and bigger. This thing can easily perforate, and that's a surgical emergency. And so you can get abdominal pain, abdominal distension. You can obviously be in shock and be acutely dying, basically, if this perforates. And you got to treat this with a few different things. You can do decompression or steroids. And of course, like we said a couple times now, sometimes surgery is the best option for something like this. The last thing I want to talk about is primary sclerosing cholangitis. I talk about this in the hepatobiliary lecture, but I do want you to think about it as a complication of UC instead of its own disease entity, because I think it's easy to remember some of the features of both UC and PSC if you consider it that way. As you can see, this is from the hepatobiliary slide. I just want you to point out that if we think about it as a complication, we'll realize that 90% of people have IBD. And then it has some of the same symptoms. So I'll show you what I mean. I think of PSC like this. You have your inflammation, it grows, and it just keeps growing, and it finally reaches your bile ducts here. That's in my head. This isn't really what happens all the time or anything like that, but in my head, this is how I think about it. And if you think about it like that, you'll realize why 90% of people with PSC end up having an inflammatory bowel disease. So it sounds like a complication. And you'll also notice that in PSC, you'll often, especially on tests, they love to. I haven't seen a primary sclerosing cholangitis that was not a complication of IBD yet on step 1 or any of the practice exams. If you'll see, you'll always see somebody who has some sort of UC symptoms as well. Okay. And here is PSC. I go over this in great detail in the hepatobiliary. I just want you to notice that even if you look at the lab values of PSC, we'll talk about P. ANCA later. That's a common laboratory findings in ulcerative colitis. You also see that in PSC. A few other things I want to differentiate between Crohn's and UC. I want you to realize that cigarette smoking is actually protective against UC, but not against Crohn's. And I just remember the UC as you can smoke. And laboratory findings, I just alluded to this on the slides with PSC. So for Crohn's, you can get a positive ASCA antibody or anti-Saccharomyces cerevisiae antibody. And in UC, you can get a positive P. ANCA antibody. For treatment of Crohn's and UC, you do not need to know the treatment algorithm. All you need to know is some of the side effects, and it's nice to at least have been exposed to some of these drugs because they will sometimes be like, hey, somebody has Crohn's, what do you treat them with? And they'll just give you one of these drugs. So it's you don't need to know this entire algorithm, but it's good to know some stuff. A good place to start is with mesalamine, which is basically aspirin that is activated in your colon. You can also try steroids, which is very common. Makes sense if it's an autoimmune condition. And then after here, there's a few different algorithms that show different things. I liked one of the algorithms that basically said, hey, if your steroids worked out, you can give them kind of a low dose immunosuppressant, azathioprine. Sorry, I can't speak right now. And then if the steroids really didn't work out as well, then you can move up to like a TNF alpha inhibitor, like infliximab. Again, I think I've seen people on TNF alpha inhibitors, even though they had a good response to steroids. So take this algorithm with a grain of salt. And then if everything fails, if nothing's working, you can kind of go to cyclosporin, which is more of a heavy hitter. The only reason I put this algorithm on is because it allows us to talk about 5 different classes of medications, and they do test those at times. They'll give you somebody with IBD who's on a medication, and they'll either give you the medication and ask for the side effects, or they'll give you a patient who has IBD and they have all these side effects, and then they make you answer what medication are they taking. So the side effects you need to know is for mesalamine, you need to know all that it can cause bleeding because it's an NSAID, and it can cause GI side effects as well. For corticosteroids, just remember its associations with psychosis, high blood pressure, high sugar levels, and Cushing syndrome. Azathioprine, it's tested more often than it should be, that if you give azathioprine with something like allopurinol, you can actually get toxicity. And the reason why this happens, if we have azathioprine here, it's actually degraded into 6-mercaptopurine, which is also a known agent in itself that you can prescribe. And then this gets degraded into an inactive metabolite. Now, this degradation here is performed by an enzyme called xanthine oxidase. The problem is if you have somebody who has like gout, let's say, and you give them a xanthine oxidase inhibitor, you can cause some issues. Because if we inhibit this enzyme, we can no longer inactivate 6-mercaptopurine or azathioprine. So these will get very big, and so you can get dangerously high levels of azathioprine if you give this in conjunction with a xanthine oxidase inhibitor. TNF alpha inhibitors, you need to know that because these are immunosuppressants, they could reactivate TB or hepatitis. So you should always order TB testing and hepatitis screen before you begin these therapies. And Cephalosporin, you just need to know that it's a nephrotoxic and neurotoxic. You also need to know for step 1 that it's a type of calcineurin inhibitor, which I actually had to look up before making this lecture because that's how low yield that last statement was. Okay, I just have 20 more facts that I really want to give you about Crohn's and UC. No, I'm just messing with you guys. You guys did great. That was a tough section. I'm going to make it easy on you guys now. We can talk about diverticulosis and diverticulitis. So in diverticulosis, it's caused by repeated straining during defecation, and this can increase your wall tension. And as you increase the wall tension, you can actually get a weakness in one of the layers of your GI tract, your muscular layer. And specifically, it's where the vasa recta penetrate the muscle layer. I'll talk about that in a little bit. And what can happen is that with this weakened layer, the first 2 layers of your GI tract closest to your lumen can actually start pushing through that layer and create a blind pouch. Let's talk about what that looks like. We have repeating straining during defecation, causing increased wall tension. So as you're straining, as you're going to the bathroom, you're actually putting a lot of pressure on your walls of your colon. This tension can create a weakness where the vasa recta penetrates the muscle layer. So here's some weaknesses here where the vasa recta penetrate. And what can happen is that the mucosa and submucosa can push through those layers, and now you have diverticulosis. I want to show you specifically where that muscular layer is getting penetrated so you have an idea. Vasa recta are capillaries that supply our bowel wall. So here's some capillaries, and they arise from the mesentery, and they have to supply the blood from out to in. So they're kind of going in this direction. The problem is that where they actually penetrate our muscular layer, it's a little bit weaker than most of our other areas. So right here can get a little bit weakened because you have these capillaries that are coming in right through this region. And when that happens, this wall tension that we just talked about from straining so much can actually push these 2 layers right here all the way through and break through that muscular layer that we just had. And because this happens, because there's actually a breakage of one of our layers, this is referred to as a false diverticulum. I've shown you these GI tract layers so many times, you're probably sick of them, but we have our lumen, mucosa, submucosa, muscular layer, and serosa. And in a true diverticulum, you have the outpouching, or the diverticula, involves every layer, whereas in a false diverticulum, you lose your muscular layer. So here's a true diverticulum where all 4 layers you can see outpouching here. That can happen in Meckel's or a true appendix. And a false diverticulum here, you can see that we've broken through our muscular layer, and now we only have 3 layers here in our diverticulum. And that can happen, and we already talked about Zanker's diverticulum earlier, but in this case, it can happen in diverticulosis as well. Risk factors for this: advanced age is a risk factor. A low fiber or a high fat diet would also cause this, or could cause this. Obesity is a risk factor. Constipation is probably the most obvious risk factor given what we talked about earlier. So now let's move on to how this presents and what can be the problems with it. Most of the time, diverticulosis is asymptomatic. One thing you should keep in mind is that it is a common cause of painless GI bleeding, especially in the elderly. It's actually the most common cause of painless rectal bleeding in older adults. Another thing you should remember is it's more commonly resulting in left lower quadrant pain when you do have pain. And that's because most of the disease is located in the sigmoid colon or the left colon as well. So it makes sense that most of the pain, if you do have it, would be localized to that region. And here you go. You can see if you're straining, that back pressure is going to come up here, and it's going to cause more diverticulosis in this region relative to others. A couple complications we should think about is diverticulitis. Well, actually, this is the main one. I'm going to have a whole slide on it in just a minute. For treatment, how do you treat diverticulosis? They like to test this, and they'll give you a bunch of answers, but the first line is always dietary modifications. Encourage a high fiber diet so that they're less constipated and that you have less wall tension and less diverticuli. You could also consider a few other, you can do reduced straining as well as like activity modifications. I don't know why they separate these. I guarantee you though, like they won't give you both of these as options on a test. They'll just give you high fiber diet. So just go with that one. I don't think they actually have tested the reduced straining as often. But let's talk about diverticulosis diverticulitis in the meantime. As the name suggests, it's an inflammation of your diverticula, and it's usually caused by obstruction by fecal material, similar to appendicitis. So remember, diverticulosis is just where you have a blind pouch, but no infection yet. In diverticulitis, you can have, let's say you have fecal obstruction here, all this area can start to get inflamed and cause some problems. This does present with left lower quadrant pain because it's an inflammation. You can also have a fever for the same reason. Leukocytosis makes sense. You diagnose this you can diagnose this by CT scan. You don't need to really know what a CT scan for diverticulitis looks like. And you treat it with antibiotics. And I don't think you need to know specific diverticulitis antibiotics necessarily. It's good to have a good grasp of some GI tract antibiotics. So I wanted to give that here. You need to make sure that you're covering your GI tract flora, which are normally gram negatives like E. coli and different types of anaerobes like B. fragilis. So here's a few example regimens that I want you to consider. You could always consider something like augmentin. And then what they like to test more though is they like to give you metronidazole, which covers your anaerobes generally, and you can take it with the fluoroquinolone, which will cover the gram negatives, an aminoglycoside, a second or third generation cephalosporin like ceftriaxone. So they like to give you some sample regimens. They'll keep it simple, and just remember that the metronidazole is your anaerobe coverage, and then these would be your gram negatives. Oh, and then Bactrim's also, I saw this Bactrim's sometimes used in the spot. I'd honestly say on tests, you're probably going to get Cipro and metronidazole or ceftriaxone and metronidazole. Probably the most common ones. I assume they're testing nowadays. Aztreonam is also an option. I didn't realize I had another option here. It's funny. Don't pick Aztreonam. I mean, I guess you could, but I haven't seen that be correct too many times. Okay, so complications of diverticulitis, you can get perforation, you can get bowel obstruction, you can get an abscess, or you can get a fistula. So let's just talk quickly about what those look like. For a perforation, that should make sense. If you have all this repeated inflammation, that could ultimately blow up and you have perforated bowel. For an obstruction, that could also make sense. If you have continued inflammation or you can get blockage in that area and get an obstruction. For an abscess, again, because it's a walled off area right now, it's hard for any drainage to happen, and it can fill up with an abscess. Fistulas can happen just like they did in Crohn's because this can contact a different organ like the bladder and start to form inflammation in both regions, ultimately leading to a fistula. And that's it for diverticulosis and diverticulitis. Let's move on to another cause of GI bleeding, angiodysplasia and HHT. So angiodysplasia is just a dilation of colonic capillary beds, and this can cause GI bleeding. So if here's our 4 layers of our GI tract. We have our lumen, mucosa, submucosa, muscular layer, and serosa. In this format, what happens is that we have capillaries and veins, and they're going to extend all the way to the mucosa, and the vein will come all the way back down. In angiodysplasia, and then you have connections between the two. What I want you to realize is that in angiodysplasia, you have dilation of all these capillary beds that are supposed to work in unison. So you have this really bad dilation, and it can cause, it basically causes too much pressure within this low pressure system, and that can result in bleeding or hematochezia. Remember that diverticulosis is the most common cause of GI bleeding in the elderly, but angiodysplasia is number 2, so keep that in mind, and colon cancer is number 3. For diagnosing this, you can find tortuous, which is kind of like windy vessels seen on angiography or colonoscopy. Here's a picture of one here on a colonoscopy. There's some associations that are rarely tested, but good to know. Angiodysplasia is associated with ESRD, von Willebrand disease, and they do test this more for step 2, but they like to test somebody who has angiodysplasia and aortic stenosis, and you just have to know that's Heidi syndrome or Haiti syndrome. That's it for angiodysplasia. We'll talk about HHT, which I always think about in my head as genetic angiodysplasia. So it's an autosomal dominant vascular disorder, and it's typified by what the name suggests, telangiectasia throughout the GI tract. I showed you this picture in the oral cavity lecture, and you can see lip telangiectasias and tongue telangiectasias. And this will present as painless bleeding. So it could be nosebleeds, any GI bleeds, and that's how it presents. And they'll usually give you a family member who's had it as well to give you an idea that, okay, this might be a genetic condition. And it can lead to arterial venous malformations in the lungs and CNS. And what happens there is that you can actually have these connections, these that shouldn't really be forming directly from the arterial or artery to the vein, and that can cause a whole host of problems as well. So now we're going to spend a decent amount of time on colon polyps and colon cancer. I promise once we get through this, the other 4 sections go pretty quickly. So a colon polyp is just a growth of colonic tissue into the lumen. It's kind of like the opposite of diverticulosis in some ways, in the sense that it grows inward instead of out. Most of these polyps are benign, but you have to remember some are pre-malignant. It usually presents asymptomatic. It's often just caught on a screening colonoscopy. But sometimes larger polyps can cause bleeds or obstructive symptoms. And so if this is our lumen, this is what some polyps might look like, just popping out into the lumen. So there's a few different ways to categorize these polyps. You can categorize them based on what you see on a colonoscopy, and that could be pedunculated or sessile. You could also categorize them by what you see under the microscope. So you can get hyperplastic polyps, adenomatous polyps, and of the adenomatous polyps, you can have a tubular polyp or a villus polyp, or a tubulovillus. So there's a few different ways to categorize them. And I want to break this down to make it easy for you to understand. So if we start with colonoscopy findings, let's talk about what a pedunculated polyp looks like versus a sessile polyp. So a pedunculated polyp is just a polyp that has attached to a stalk. So you can see the stalk on colonoscopy. Whereas a sessile polyp has more of a broad attachment to the colon, where you don't get that fine stalk that attaches the polyp into their lumen. So if we look at the lumen here, a pedunculated polyp would look like this because it's attached to this nice stalk here. It's very easily to understand where it's protruding out from the colonic wall. The problem with sessile polyps is that they have this broader attachment that kind of attaches like this. And this is actually a risk factor because sometimes you'll remove this sessile polyp, but you're not really sure if you got it all. And if it's pre-malignant, it could increase your colon cancer risk. So that's why having a sessile polyp in of itself is a risk factor for colon cancer. So let's talk about what you find under a microscope now. So if you have a polyp and you biopsy it, you can get one of 2 things. You can either get a hyperplastic polyp or you can get an adenoma. So hyperplastic polyps are very common, And fortunately, they're benign. They're not even pre-malignant, completely benign. They have something called a serrated histology or a sawtooth histology. So here is a benign hyperplastic polyp. Just remember that serrated is a sawtooth pattern, and you can kind of see that here, the sawtooth pattern as I've drawn in. Now let's talk about adenomas, because this is more often tested. Adenomas themselves are benign, but they can be pre-malignant through the adenoma carcinoma sequence that we'll talk about in a little bit. I guess we'll talk about it right now. The adenoma carcinoma sequence we'll go over. What I want you to know with adenomas is that there are two subtypes of adenomas. There are tubular adenomas and villus adenomas. So tubular adenomas are the most common type of adenoma, and I'll have a picture of it here, which actually shows both subtypes, to be honest with you. So it's our most common type, and as the name suggests, it's composed of tubules. So in this region here, you can see all these little tubes, all these little circular structures. These are tubules. That's actually a tubular adenoma. I just want to point out that this polyp is probably tubulovillus because there is actually a villus portion right here. And we'll talk about what the villus looks like. The finger-like projection here typifies a villus adenoma. So villus adenomas are more often sessile, which again is even a worse risk factor, and they have the highest risk of developing malignancy. And we remember that because villus adenomas are the villains because they're causing cancer. So here's a picture of a villus adenoma. Villus just means you'll see finger-like projections like this right here, boom, boom. I always think of this guy. I don't know if anybody's ever seen Osmosis Jones, but this is the villain. This is Thrax, Anthrax guy. He's got this long nail here, and I just remind, if I ever see Thrax's long nails here, I know that's a villus adenoma. Before we talk about colon cancer, I want to talk about a few more polyps that are often tested, and those subtypes are called juvenile polyps. So a juvenile polyp is a hamartomatous polyp. What the heck does that mean? So a hamartoma is a mostly benign collection of cells. So it's mostly benign, but it can be cancerous. And you'll see juvenile polyps in two different syndromes, either juvenile polyposis syndrome and Peutz-Jeghers. Let's start with juvenile polyposis syndrome. This is an autosomal dominant disorder. And as the name suggests, you get multiple juvenile polyps, usually found in the rectum. And so because of all these polyps, your presentation is going to include painless rectal bleeding. And because they're mostly benign, but do have some malignant potential, this does increase your cancer risk. So you have to get surveillance colonoscopies. I think of these, the more high yield disorder is this Peutz-Jeghers syndrome, also an autosomal dominant disorder, also causes hamartomatous polyps, but this one can cause it throughout the GI tract. A big thing they like to test is that it also has this thing called hyperpigmented macules. So if I go here to Peutz-Jeghers syndrome, you're going to see a few things. The first thing you'll see is this hamartomatous polyp throughout the GI tract. And this is a hamartoma. I think this is a lung hamartoma, actually, but I just want you to know it's just like this ball of cells that is usually benign but can be cancerous. But what they like in Peutz-Jeghers, they love this hyperpigmented macule. So hyperpigmented just means dark, and a macule is just a non-elevated small area of skin. So it's not a raised area. It's just these small dark areas on your lips. And how I remember Peutz-Jeghers causing this specifically, I always think about people who have Peutz-Jeghers look like they put Jaeger on their lips. So Jaeger, if you don't know, is an alcoholic drink that's really, really dark in color. So I just think, okay, these people just smeared some Jaeger on their lips and Peutz-Jeghers. And as we just talked about, all these hamartomatous polyps do have malignant potential. So there's an increased cancer risk here. Now let's move on to colon cancer. Colon cancer is the third most common cancer if we exclude skin. It's the third most deadly cancer as well. There's an incidence, a peak in their 60s, so it's a cancer of older adults generally. How this presents, oftentimes it's asymptomatic, which is one of the reasons why we do those cancer screens and polyp screens, actually. Presents with GI bleeding, especially in the right side. So if you ever have a patient who's having some iron deficiency anemia in the elderly, you have to assume it's colon cancer until you can prove otherwise, because it's so common in that age group. You can also get bowel obstruction symptoms, especially with left-sided tumors. We kind of went into this a little bit with the anatomy section. It's because on your left side, your stool is more well-formed and you have a lower diameter, so it's more likely to cause obstruction on that side. You need to know both pathways from which colon cancer can arise, okay? There's the adenoma carcinoma sequence, which I've alluded to a little bit in the polyp section. And there's also something called the microsatellite instability pathway, or the MSI pathway. Let's talk about the adenoma carcinoma sequence first. Here's from our colon polyp histology slide. I told you that some adenomas are able to progress to carcinoma through this sequence. So how does this sequence work? So first off, you have a normal colon. Then something happens, some mutation happens that causes this abnormal colon. But nothing happens yet. There's not even a polyp that forms. It just increases your risk a little bit. Another mutation can happen that actually forms the polyp itself, which again is not cancerous yet. But the problem is another mutation can finally come and change that polyp, the adenoma, into a carcinoma. So you can see there's three different things that kind of happen here to go from normal colon all the way to a carcinoma. So what are those things? Well, the first mutation that happens is an APC mutation in chromosome 5. And this can increase your risk of polyp formation. The second mutation that'll happen is something called a KRAS mutation, which will, if you have a KRAS mutation at this site, you'll end up forming an adenoma. Finally, that adenoma can transform into a carcinoma through a p53 mutation, as well as increased COX-2 expression to form carcinoma. A good mnemonic for this is, instead of the common firearm, the AK-47, you can think of the AK-53, and which will tell you the mutations that happen in the order of APC, KRAS, and then your guardian of the genome, P53. Another thing they sometimes mention is that aspirin can decrease the risk of colon cancer because, as you can see right here, progressing from adenoma to carcinoma requires excessive COX-2 expression, and aspirin can inhibit that. I'm going to talk about some hereditary syndromes that can cause colon cancer. There's two hereditary syndromes we need to know, FAP and Lynch syndrome. So we'll start with FAP. So familial adenomatous polyposis is a germline mutation of one of those APC genes that we just saw earlier. So right here, you notice if we have this APC mutation already in play, it'll increase your risk of colon cancer because you're already one step ahead of the game. Something I want to point out here that I haven't got to talk about in the other lectures yet is the theory of the double hit hypothesis. So the double hit hypothesis states that both alleles must be damaged in order to create a mutation. So in a normal person, we have two alleles. It's kind of hard to get a mutation in one specific area because, well, actually, and then here's the alleles for FAP. Going back to a normal mutation here. Oh, I guess I do that in the opposite way. Never mind. Okay. So starting with FAP, it already has one germline mutation of the APC. And so now what I've been trying to talk about for the last 30 seconds is that in normal individuals here, in order to get this mutation to occur, you need to have a random mutation in this, which is, let's just say like a 1 in a million chance, okay? And then you also have to have another mutation in that same allele in that same region. So it's like a 1 in a million chance squared almost, right? Very unlikely to happen. And in FAP though, because every cell in your body already has this mutation, it's a near certainty that one of your cells at least is going to have this mutation here, because it's no longer 1 in a million squared. Sure, it's still a 1 in a million chance, but you have millions of cells anyway, so it's going to happen. So that's why in these hereditary conditions where you already lose one of your APC genes, you're at super high risk of progressing to cancer. And in fact, in FAP, the risk is so high that you'll get thousands of polyps developing, and you basically have 100% chance of getting colon cancer, just because of that one germline mutation. And so to treat this, you have to remove the colon, and you should do it the soon as it's, deemed a decent time. As soon as you're deemed a decent surgical candidate, it's reasonable to do it because of your extremely high risk. There's some syndromes that they sometimes test, so I'm just going to mention it here. And there's something called Gardner syndrome, which is where you get FAP and then you get fibromas and you get which is just connective tissue balls. You can get osteomas, which are, bone, like little balls of bone tissue, and then you can get cysts on your skin. And I like to remember this when I think of gardeners, I think of them just kind of getting down and dirty and, working hard, and they end up with all these sores on their hands. And that's kind of what happens. In Gardner syndrome, you get bumps everywhere. You get polyps, you get skin tissue cysts, bone cysts, whatever. The other FAP syndrome they sometimes test is Turcotte syndrome, which is FAP plus CNS tumors. And I remember Turcotte, I think of turban, to remind me that it's some sort of head pathology associated with FAP. Now that we've drilled the adenoma carcinoma sequence into your head, we can talk about the MSI pathway. So microsatellite instability pathway is a totally different pathway. Everything I just talked about, I want you to forget, because this has nothing to do with polyp formation and kind of having that nice progression. This is just a completely different pathway. So microsatellites are repeating sequences of non-coding DNA. So they might look something like that, okay? DNA mismatch repair enzymes are important to know because these can fix mismatched base pairs when they replicate. So let's say you have an AC that, that adenine should not bind to thymine. So this mismatch repair can say, wait a second, let me fix that, and it'll fix it. If you have defective mismatch repair enzymes, that can ultimately lead to microsatellite instability. And microsatellite instability is basically just stating that you have increased numbers of microsatellites during cellular division. So on the right here, if you don't have your MMR enzyme, what's going to happen is that you have these elongating chains of microsatellites. I don't know why I can't speak right now. And when you have these elongating chains of microsatellites and you have defective mismatch repair enzymes, it can ultimately lead to cancer. And this cancer does not arise from a polyp like our previous one. It just arises out of thin air. So Lynch syndrome is an inherited DNA mismatch repair enzyme mutation. So just as FAP was like our germline APC mutation, this is our germline mismatch repair enzyme mutation. And so if you have defective MMR enzymes, you're going to get microsatellite instability, and you're going to ultimately have colon cancer. And again, I just keep wanting to reiterate, you do not get that adenoma first. It's just the colon cancer just pops up. Sometimes you'll hear this referred to as HNPCC, or hereditary non-polyposis colon cancer. Again, just kind of emphasizing that there's no polyps in Lynch syndrome. You're going to see on tests, even for FAP, I should have mentioned, they'll always give you a significant family cancer history if they want you to kind of go along the lines of some rare genetic syndrome. It's usually on the right side more than the left. People with Lynch syndrome have an 80% chance of being diagnosed with colon cancer. And unfortunately, they have other risks of cancers as well in their endometrium, ovaries, stomach, and other cancers locations. The last thing I want to mention with colon cancer is a few different things here. We'll start with metastases. So most colon cancer, the first thing it likes to do is spread to the liver. And that kind of applies to the entire GI tract. And if we look at the blood flow here, moving from left to right, we have our portal veins that drain into our liver, right? So, and this drains into our hepatic vein and ultimately out to the IVC. So what drains into the portal veins in the first place is our GI tract. So if you had some sort of cancer and you wanted to release little cancer cells throughout your body, it would first go to the portal vein and then it would end up in the liver. And this is from our liver section, which comes up later on. You can see that right here, the GI tract is the most common primary cancer site for liver metastases. And oftentimes they'll ask you a question like this, where they basically say, hey, this patient comes in, they're not looking well, they got, weight loss, abdominal pain, it just sounds kind of cancery. And they'll give you this picture where you have a ton of liver mets here. And they're trying to trick you by hoping you pick hepatocellular carcinoma, but primary liver cancer would not be in this many places. This is most likely going to be colorectal cancer that has spread to the liver. I've touched on laterality a little bit, but I want to emphasize it and kind of give you a good mnemonic so that you never have to worry about this, which left-sided versus right-sided does what. So left-sided tumors, we've talked about this, so I hope you get this one right. The left-sided tumors, because the stool is more well-formed as it nears the end of the GI tract, and your diameter is shorter, you're more prone to obstruction, whereas right-sided tumors are actually more prone to bleeding. The pathogenesis is important, so left-sided tumors often follow that adenoma-carcinoma sequence that we discussed first, whereas right-sided tumors are more known with microsatellite instability and Lynch syndrome. I kind of give it away here, but left-sided tumors would be, because it's an adenoma-carcinoma sequence, it should make sense that FAP would cause more left-sided tumors, and then Lynch syndrome would cause more right-sided tumors because it's associated with microsatellite instability. My mnemonic here is I always remember that everything on the right has 5 letters in it. So right has 5 letters, bleed has 5 letters, micro has 5 letters, and Lynch has 5 letters. So whenever I'm thinking, well, what is this? Right-sided, left-sided, what's going on? I just remember this, the 5-sided rule, the 5-letter rule. The last thing I want to talk about with colon cancer is colon cancer screening. So who is eligible to get a colonoscopy? A couple guidelines I want you to know. The first one I want you to know is that you should start screening at age 50. A lot of guidelines are starting to say 45. I don't think they'll test you on that middle ground, but it's just an idea. Everybody should have a screening colonoscopy at age 50. Any patient who has GI bleeding or iron deficiency anemia should get a colonoscopy. Again, this really isn't a screen anymore. Now you're actually trying to, make sure they don't have it. But anybody with iron deficiency anemia, they love to test that. If you see somebody with strep bovis endocarditis, don't forget that's an indication they may have colon cancer. We talked about this earlier though, but basically you just need to know if somebody's at ulcerative colitis for several years, you need to screen them. And something I haven't mentioned yet though, is that if somebody has primary sclerosing cholangitis, which was a complication of UC, you need to get a colonoscopy right away because there's a high likelihood that they've had UC for quite some years now, and it could have spread. It could have basically caused colon cancer already at that point. Another thing I just want to point out is please do not order like CEA levels to screen for colon cancer. It's really not useful for that. It's only useful for known colon cancer, and then you can kind of assess it for recurrence or progression in people who already have colon cancer, but you can't just screen everybody with it. Bad idea. Okay, now we're going to finish it off with a few quick ones here. So ischemic colitis is ischemia. It's the name kind of speaks for itself. It's ischemia to the colon, and the damage is often done in susceptible areas. The damage is usually reversible, and it's located in watershed areas of the colon, which we talked about earlier, the splenic flexure and the rectosigmoid junction. So again, here are the two regions that can be affected most by hypotension. The reason why that happens is because you have really high perfusion pressures right here, just off of the main arteries. But as you get deeper and deeper, more and more distal to these main supplies, this pressure here is lower. So if you lose all your systemic pressure, this region would be the first to get damaged from that. It's caused by either atherosclerosis, but more often than not, especially on tests, they're going to give you some sort of very obvious hypotensive episode. Like, guy comes in with, he has shock, they fix him up, he's doing okay, but now he's got all this bloody stool, then I want you to think ischemic colitis. So for atherosclerosis, you can imagine if you have a clot in one of your main arteries or just a plaque, then you'll already start with diminished blood supply in the first place. And so by the time you actually get out here, you're going to run into some problems. And likewise, for a hypotensive episode, if you don't have as much blood supply coming in general, you're just going to have decreased blood supply. And again, you can see who's getting affected most. It's these regions here: splenic flexure, rectosigmoid junction. This presents kind of like I just described a little bit ago. You'll get abdominal pain, bloody stools following one of these precipitating episodes. Okay, so for volvulus, I did talk about one of the types of volvulus in the small intestine lecture, and I'll revisit that here. So let's go over, there's three different types of volvulus. So a volvulus is a twisting of the colon around its own mesentery. And the problem with this is that if you're twisting that region of intestine, it can obstruct the bowel, and it could also lead to infarction of that segment. So here you can see a twisted segment around its mesentery. You can imagine that if a stool's trying to get in here, it could get obstructed. And also remember that the blood supply is coming on in here. And if you're twisting that blood supply, you can also get infarction of this region due to hypoperfusion. There's a few subtypes I want you to recognize. The most high yield by far is the sigmoid volvulus that occurs in the elderly. You can also get cecal volvulus in young adults. And lastly, you can have a midgut volvulus in neonates. So starting with the sigmoid volvulus, this will present with an older person with low abdominal pain, constipation, and lack of flatulence. And to diagnose it, you just need to get imaging studies and find this big coffee bean sign right here. Once you see that, you have your diagnosis. Here's some coffee beans just so you have an idea. It kind of does look like a coffee bean. To treat this, you gotta do a sigmoidoscopy, and usually you surgically correct it. Now, cecal volvulus looks pretty similar, but I mean, you can see some differences. Here's the sigmoid again if you wanted to see it. For cecal volvulus, it's usually seen in young adults. And what happens here is that for some reason, during embryology, the cecum is not attached 100% to its mesentery. And because of that, it has a little bit of mobility. And with that mobility, it can twist around itself and cause a volvulus. And here you can see, again, this huge, kind of like a coffee bean, but the location's a little different. and that's with a young adult who has a cecal volvulus. And the same thing, you can treat it. You either have to remove part of the colon with the hemicolectomy, or if you can reverse this torsion, you can actually attach the cecum back to a wall so it doesn't twist on itself in a procedure called a cecopexy. Now, midgut volvulus we talked about in the intestinal malrotation section. And so again, this is related to malrotation, and it's because the lad bands can basically predispose the intestines to twist around themselves. So what happens here is that in lad bands normally attach the cecum to the right lower quadrant. So if this is our normal colon, lad bands can attach to the right lower quadrant and everything's good. The problem is that if you have malrotation, your cecum might be in the right upper quadrant here. And so a lad band attaching to it could actually cause an obstruction, especially in this duodenum right here. It can cause an obstruction or a twisting, or volvulus in that region. So how this will present is bilious vomiting during the first weeks of life. You'll also get transient abdominal pain. You can diagnose this through imaging studies. You'll see air fluid levels on abdominal x-ray, which I talk about in the small intestine lecture, in the small bowel obstruction, what air fluid level looks like. And you have to treat this surgically as well, generally. Okay, I'm going to go over what ileus is versus Ogilvie syndrome. So ileus is a temporary loss of bowel peristalsis. It's going to affect both the small intestine and the colon. It's caused, there's a number of causes, but some of the common ones. Recent surgery. After recent surgery, some people can have an ileus. Certain medications can cause it. And for how this presents, it's going to be somebody who's constipated or obstipated. They're not going to have many bowel sounds because of this temporary loss of peristalsis. And you could easily develop nausea and vomiting and abdominal pain as this evolves into a small bowel obstruction. Ogilvie syndrome sounds somewhat familiar, but they'll give you some key differentiating factors on the question stem if they want you to pick this one specifically. So this is called colonic pseudoobstruction. It's typified by massive colonic distension, but no evidence of obstruction. And what I want to point out here is that the disease exclusively affects the colon, whereas in ileus, it affects both the small intestine and colon. Ogilvie syndrome, you're only going to see in very, very sick patients or in post-surgical patients. Okay, usually a hospitalized or nursing home patient is very common on the question stem because they don't want to trick you. They have to make sure that it's a fair question and that Ogilvie syndrome has to be the answer. If they give you a question with somebody who's kind of not that sick, I want you to not think of Ogilvie syndrome because they're going to give you a classic presentation if they want you to pick that. It's also associated with narcotic use as well. Okay, our last section here is just on a childhood disorder, Meconium Ileus and Hirschsprung disease. So Meconium Ileus, meconium is just a newborn's first poop. And so Meconium Ileus is just a lack of defecation within 24 to 48 hours of life. This is associated with cystic fibrosis. And the reason this happens is that in cystic fibrosis, there's usually a thicker consistency of stool. And because of that, the stool can actually create this meconium plug that obstructs the bowel and prevents any defecation whatsoever. And usually you have to go in and either treat this with an enema or surgery in some cases. On the other hand, Hirschsprung disease has a different pathogenesis. It's related to a failed migration of neural crest cells to the distal colon. And what happens is because you don't have these neural crest cells, you lose those myenteric neurons that I've been talking about that are responsible for motor movements like peristalsis. And if you don't have peristalsis, just like we saw with toxic megacolon, you get the same megacolon and Hirschsprung disease. So let's talk about what happens here. This is our embryologic GI tract where we have our foregut, midgut, and hindgut. Normally, the neural crest cells migrate. So they start in the foregut and they start migrating down the GI tract and everything's fine. In Hirschsprung disease, however, they fail to migrate 100%. And because of that, we have a specific region like right here that's not going to have those myenteric neurons. So if this is our lumen, mucosa, submucosa, muscular layer, and serosa or adventitia, we know that we have our third layer is our muscular layer, right? So you have your circular layer, and we have our myenteric plexus, which we've talked about now many times as being the nerves that supply peristalsis. And then you have your outer longitudinal layer. And just remember that the myenteric plexus also regulates sphincter tone. In this case, we're talking about the importance of peristaltic contractions when it comes to the myenteric plexus. So when you lose that, just like our ulcerative colitis complication here, it's the exact same thing where you lose peristalsis in one area because of damage to the myenteric plexus, and that'll cause a backup and a distension proximal to that area. And as you can see, I didn't change much. I have the exact same image. It's failed migration of neural crest cells that cause nothing here, and ultimately you're going to get distension proximally. The risk factors for Hirschsprung's important ones to know are the RET gene mutations, and the really important one to know is its association with Down syndrome. This can also present as a failure to pass meconium. You'll get obstructive symptoms like you'd expect, abdominal pain, distension, and bilious emesis. And then you might get chronic constipation as well. Sometimes they'll give, I don't know if they give you it too often on tests, but I think I had a practice problem where a child had chronic constipation and he ended up having like partial Hirschsprung as the answer. So when you evaluate this, there's a classic description of a squirt sign on physical exam where you, let me see if I have it. Yeah, right here. So it's basically you do a digital rectal exam and nothing's wrong, but as you pull out of the anal canal, there's going to be an explosion of feces due to changes in pressure. On x-ray, you're going to see a dilated bowel with no air in the rectum, and you'll also see toxic megacolon like we showed earlier. Here's another picture of it. You can see right here. This whole region that I just highlighted appears to not have received myenteric neurons, so it can't facilitate peristalsis. So you can see how everything proximal to it is getting like very distended. So the gold standard to diagnose this is actually through a rectal suction biopsy, and that will show you an absence of ganglion cells, which makes sense because there's no migrating neural crest cells in that area. And to treat this, you need to treat the affected area by removing it surgically and then connecting or anastomosing healthy bowel segments. So that's it for the colon lecture. I appreciate you all for sticking around. I think next up will be the rectum lecture. So thanks for stopping by.